Yeah, wherever you.
Thank you. Good morning. This is another of the lecture series in the Human Systems Academy. My name is Janice Hall, for those who don't know me. And Dr. Helen Lane was the one who got this started, and I have inherited this, and we're taking it to the next level. And we are excited for those of you who are close to getting your ROI certificates. And for those who are not, you're on your way, and you'll take these classes. And we have a series of lectures that some of them are electives, some of them are required classes. But this one, Dr. Fogerty has agreed to do for us, and she's going to give a self-introduction of her credentials on why we asked her to do what we asked her to do. Exactly, and so I'll turn it over to her, and thank you very much. We're excited to have you.
Thank you, Janice. So good morning. Thanks for being here. Appreciate your time and attention. I know it's hard to get away sometimes. So I am Dr. Jen Fogerty. I've been with the directorate 10 years now. PhD in medical physiology. I came on board and specialized in the cardiovascular discipline for a couple of years, moved more into a broader kind of risk management job. I work a lot with the Health and Medical Technical Authority on a wide array of technical issues and how they work into our human system requirements and how they interface with programs and whether we get compliance or not. My role in VIIP started back when things were kind of first evolving and we were trying to understand, was this unique to an individual or a much larger issue, and where did it fit into the context of aerospace physiology? So I actually gave this lecture first. You'll see the date on here is January 17th of 2013. So some stuff has happened between then and now, but this is still, I think, a reasonable introductory lecture. It's a big picture of how we got where we are today. We are planning some follow-on lectures with Dr. Christian Otto, Dr. Yael Barr, who are much more entrenched in the current research and the day-to-day activity of trying to figure out exactly what the mechanism is behind this and if we have any way of really addressing the problem. I mean, there are some changes in spaceflight that you just are a matter of fact that you're not going to prevent, but you have to deal with. You probably could compensate in some way or provide a countermeasure, or you just have to be prepared to deal with the consequences and understand them. So this, again, is probably a big picture lecture for you. I'm willing to take questions throughout the lecture if they come up. Sometimes it's hard to address a question 20 slides later. So feel free to just get my attention, and we'll do our best, and I'll repeat them for the videotape so people who watch this later can understand what you're asking. So really, there's a lot of contributors, as you know. Anytime anyone from our world gives a lecture, there is quite the army of individuals that are usually behind the data that's presented. We don't work alone in any way, shape, or form, so there's a lot of people to give credit to. We're constantly amassing data, reanalyzing it, using publications from funded research versus data that was gathered through medical requirements. So I think a lot of you are represented here today. I see LSAH out there. So it's never one person who does any of this work, for sure. Dave Francisco has been playing an integral role, like from a directorate level, to do some integration. He has a very interesting perspective on from engineering and project management, so he's been helpful in kind of streamlining some of our thought processes. J.D. Polk, some of you may remember. If you're new, you may not know that name, but he was actually branch chief and then division chief over in SD. So he was very instrumental at the time at really attacking the problem on the ops side. He pushed a lot of stuff in terms of what we were doing from an imaging perspective, which I'll touch on throughout the discussion. It's very interesting in our world because you're taking images of healthy people and then getting some results that you may have difficult interpreting because we don't have the database in normal, believe it or not. Most of the time people go and get images done when they're sick or having symptoms, so it's usually in that context that the doctor's trying to understand what it means. When you take a relatively healthy person and get images, you may not really understand what that image is telling you or what it predicts. Ashot Sargassian, really key with the ultrasound and the intermodality work with MRI. So really the gold standard, which we struggle with terrestrially is MRI. Well, we're not going to do that in space. You're not going to get that data. So what instrumentation do we use and how do we interpret it? Doug Hamilton, he's kind of, I think, working still with us part-time. He's up in Canada. Very eclectic individual, trained in a lot of different disciplines. He brought a lot to the table, and he was involved very early on. Of course, we mentioned the lifetime surveillance of astronaut health. We have our epidemiologist on board and our biostatisticians. BIDRA is another group, biomedical data reduction and analysis. They kind of crunch the numbers on the medical requirements that we get on every individual that flies long-duration space flight. And we use them kind of as this backstop data. I'll give you a chart that has a bunch of graphs on it, and we'll just talk about that at a very high level. But BIDRA is really instrumental for us to step back and look at an individual in the context of all the people who have flown long-duration space flight for the given type of data we get every time. So it's the most consistent data set. Of course, we have HRP, the Human Research Program, and the Human Health Encounters element, which is located in the HACD, no, what are they called now? SKs. I'm sorry, I'm a little out of loop with the reorg. So they're over in SK. So we have the VIIP RCAP. So for the Visual Impairment Intracranial Pressure Project, you have the Research and Clinical Advisory Panel. We have a group of outsiders we meet with regularly to kind of give us a reality check and a sanity check. So they've been really instrumental in us building the portfolio of work, understanding what we should push into operations and have the rationale to push into operations versus what we're going to put on the research side. And then we have the VIIP IWG, which is the Imaging Working Group. That goes back to the ultrasound, the MRI, the fundoscopy, the optical coherence tomography. We have a lot of instrumentation and get a lot of images, but what it means for each image and then what do the images mean against each other, it takes a little bit of a group to figure that out. So we built a little bit of an agenda to kind of give some structure to the talk because we've been doing spaceflight for over 50 years in the United States, and it says, how come this is new? So it's a good question to ask. So we'll talk a little bit about the type of programs we've had in the past, some of the findings that might have indicated we should have looked for something or maybe gave us data that said there wasn't anything to look for. So there's some historical context. Then there's just spaceflight physiology. How is the body affected by spaceflight? The data we collect, the countermeasures we do, which also introduce a variable into any of the equations we're trying to work out. And then you have transition to operations. And when I thought about transition to operations, what I mean by that and what the Tech Authority means by that is how do we take stuff out of research or the commercial off-the-shelf type approach and apply it to what we do in operations. And there's a process in there. What we're trying to do really is risk management. How does this new thing, whether it's hardware or a process, affect the output? And is it to our benefit to do it? Does it reduce the risk in some way? Or does it drive some sort of efficiency? Do we do our work better, faster, but we don't change the ultimate risk outcome, but we become more effective and efficient in the middle? And then we'll talk, the second half of the talk is really dedicated to what we knew about VIIP at the time, kind of the hypotheses, which I think are still really open-ended right now because we accrue data very slowly. We only fly a couple people a year because they're going for 6 months at a time. We get a lot of data on any given person, but when you start amassing that kind of data on one individual, and you'll see the variability that we have, to get to a rock-solid conclusion is going to take you a little while. So some context. When we go out and talk to the outside world, and you guys might be more familiar with this since you're in the community, the bulk of our knowledge sits around 2 weeks. Of spaceflight exposure. And that, of course, goes back to historical missions, but mainly shuttle, when you were flying 10, 12 people at a time and could amass a good amount of data on any mission. But it's within that time frame. So that's what you were working with. And we all know that in terms of how the human body works, there are acute changes and there are chronic changes. And there are changes that can manifest due to an instantaneous exposure versus changes that happen because of a chronic exposure. So the body is one of the most amazing pieces of machinery we've ever seen, and it can adapt wildly. It also can be pretty resistant to things and not like a stimulus very much and react kind of violently. So when you're trying to manage the understanding of the terrestrial experience and then what spaceflight throws in, the 2-week exposure could lead you to believe one thing, where a 6-month exposure is a totally different result. So you have to be a little open-minded when you take the conclusions from 2-week missions and try to apply them to long duration. The other issue, we can talk a little bit more if you have some questions, is how we've been able to collect data and the limitations about in-flight data collection, which impair your ability to have time course. So we tend to do a lot of our data collection pre and post-flight. You can amass a lot of N number in those pre-post, but they're 2 little dots on a graph. And if they're different than each other, you get to draw the line between those 2 dots pretty much any way you'd like. You probably have some evidence and rationale for how you connect those dots, but that's where a lot of the debate can occur because you don't have the data points filling in that line. Well, and for any given mission, you could project, okay, for another 2-week mission, this is what I would expect based on prior 2-week data. Where you really struggle is to extrapolate out to further time points. Because what did it look like? How did you get there? You know, what did the actual graph look like? And so if we had more data in the middle, you could say, well, if it was trending down and was on a negative slope the whole time, do I predict that it would continue negative or continue positive? You know, would the response be bimodal? So we have a lot of questions of using 2-week data and applying it to anything longer than that because of the limitations of the lack of in-flight data collection. So from a historical perspective, you say, well, what did we know and when did we know it? Well, so we have Gemini, 8-day missions, and there really were no noted changes in visual acuity. So we're going to stick kind of with that theme. There's a lot of other body systems to talk about, but in the end, the functional deficit we'd be concerned about was the change in your vision. Apollo, no visual changes that were measured. And again, this was mostly pre and post flight. They had communication with the crew during the mission, but there was nothing notable in either of those mission lengths. Shuttle. This is actually when we started to see some data with changes in vision. And we started to ask some good questions and do a lot more testing pre and post flight with the changes in shuttle vision. There were a lot of theories about why vision changed. Remember, the humidity was kind of low and your vision is affected by the dryness of your eye. So that can explain things. You can add fluid back and see if that, moisture back to your eye and see if that corrected it. They looked a little bit deeper and there was no optic disc edema. But when we look back at the data for those people who had the images done, there were occasional choroidal folds. And the choroid is a part of the back of the eye, that can swell. And when it swells, it's restricted in its volume, so it has to fold on itself. So there's something very notable about a choroidal fold. Told you that you had swelling in the back of the eye. So we had a little bit of an indication that something was going on in shuttle. But actually, because it resolved post-flight and pretty quickly, it wasn't seen as a big issue. It was one of those that was kind of noted and put to rest, and we didn't follow up. There didn't appear to be any long-term deficit or effect from it, so it wasn't followed up from an occupational surveillance perspective either. But during the annual exam, we do a vision exam on the astronauts and collect that data every year, and we didn't find anything notable in terms of astronauts having worse outcomes or different outcomes than generally healthy people. So there was nothing alarming about the shuttle data. But we do have to acknowledge there's some differences between historically what was going on in the present. That's where we say we can't exactly use all of that rationale from Shuttle, Apollo, and Gemini to predict that there wouldn't be anything wrong in the ISS. So again, we're having very different time lengths. The notable exception was Skylab, and Skylab was really dedicated toward biomedical research on the astronauts. And during Skylab, we actually didn't see, with the longest mission being 3 months, a notable change in vision or any artifact in the back of the eye in terms of the anatomy. But it is confined to 9 people. So again, statistically, those 9 people could have been different than others or not susceptible in some way. So what you say is only true for the 9 people that flew. If we flew 150 people on Skylab, maybe we would have found something. We've also had a phenomenon, and this has to be recognized, and we've briefed the astronaut corps, and it can be entertaining at times, but the average age is older now by almost 10 years. And we all know with aging, the fact of life is your tissues get more rigid. And it's not something you can really reverse. We can slow it down. We know healthy ways of living. We know antioxidants improve those things. But the reality is your tissues are getting stiffer, they're less elastic. And so if you change a volume of fluid in a confined compartment and something's less elastic, you get higher pressures. So we wonder how much, and we have biostatisticians helping us track what is the age effect, and is that really a central player in this, or is this just kind of one of those variables rolling around in the background? Historically, we were not doing MRI and OCT on the astronauts. One, a lot of the technologies are newly available, not MRI so much, but the OCT, the optical coherence tomography. But what's interesting is when you work on the operational side, you need pretty strong rationale to do a clinical test on a person who's not ill, right? Because you do have trouble interpreting the data. So we are, on the operational side, a little resistant to going there, because if you find something and you don't know what it means, now what do you do about it? Whereas if someone's overtly showing symptoms, it makes sense to go do the test and kind of troubleshoot the problem. The research side is the one that pushes the limits and has to open the gateway to collecting that data. But we have a lot of priorities in the research portfolio, so it's competing amongst a lot of things and maybe always doesn't happen in the sequence that makes sense retrospectively. We do definitely have a longer mission duration with 6 months, and we're pushing ISS to 12 months now. So we have a lot of questions about moving out to a 12-month mission and what we're going to find. We actually are working at 14.7 PSI, 21% oxygen, which is normal pressure, temperature. So we don't have that as a variable currently, but they are suggesting for future missions to alter some of those pressure and oxygen concentrations. And we have a lot of good questions about how that'll affect these processes. And it's a lot of unknowns right now. And we have a robust exercise suite, which has both been proposed to be a good thing and maybe not such a good thing. Obviously, when you look at the data from a whole body perspective, skeletal muscle, the musculoskeletal system, robust exercise is the right thing to have. Cardiovascularly, it's the right thing to have. When you start talking about shifting fluid and changing pressures, sometimes exercise causes a question mark. We have certain groups, our international partners have expressed some concern about our advanced resistive exercise device and the type of intrathoracic pressures a person can generate. We've got questions about the treadmill. So as much as these things are part of their daily life and considered robust countermeasures, we wonder what role they're playing in any of this for any given individual who might have a susceptibility. So you'll see with the N numbers that we have to deal with, we're not going to resolve all these variables very quickly. So just as an overview, the human response to spaceflight, this chart has been floating around for a lot of years. I think it's one of the more comprehensive. But the astronauts really experience a spectrum of adaptations to spaceflight. They have a variety of exposures. So we have instantaneous G-load at launch and landing. We have the long-duration microgravity exposure, which we all believe is playing a central role in what we see as aerospace physiology and VIIP. The closed environment, any point in time we can get a contaminant in the air or water. So depending on what happens to whom, we would go back and try to understand, was there something anomalous found in any one of those systems? Or is there some way to protect for that in the future? The confined habitat, psychosocial stress, and the role that plays in the human body hormonally cannot be overlooked, but we don't exactly know how to quantify it at this point. Radiation exposure. Obviously, we spend a considerable amount of time and money thinking about the galactic cosmic radiation that the astronauts are exposed to and the potential health impacts that has. I can't say we have answers right now, but we have a lot of speculation. We terrestrially understand the types of radiation people get here and the stressor that is and how the body on a cellular level responds. We're still trying to understand it from a spaceflight perspective. So we have to understand the role of the neurovestibular system, cardiovascular, skeletal, muscular, immunological. Obviously, we provide the nutrition and we track it, but how your body treats the food has some question marks. You'll see also that when it comes to medication, the GI motility and your absorption rates have been affected. And of course, we mentioned the behavioral and the stress component. This is another chart everyone loves to hate, but it's probably the most comprehensive in terms of getting a ton of information in one place at one time. What it really tries to illustrate to folks is that there's a time course of change that we think we've been able to document. You can go back to the literature, there's citations for each one of those lines. And I'll be honest with you, a lot of those lines, the data is only pre-post. So they've drawn the slope of the line or the shape of the line out of other kind of teleological rationale. But the deal is you have changes that occur very quickly in spaceflight, like the neurovestibular. There's a perturbation, they adapt, they recover, they function well. You have fluid and electrolytes. It shifts, your body adapts, you function well. What it also tells you on the flip side, there's going to be a counter-reaction when you come back, which is why you have that instability in the first kind of week to 10 days post-flight when your body's readapting. Again, some of those can recover within 24 to 48 hours. Others take days to weeks. But we also have to note, and you'll see some of our requirements testing tells you that you don't have much reserve. So while you look like you're functioning okay, you can walk away, you probably can't run away. You probably can deal and manage with kind of low-level stress, but if we put you under high heat and high psychological stress, you really fail at that point because you just have no reserve. Some of the longer-term changes that take longer to return back are like the bone and how your bone mineral density is altered in the architecture of the bone. And that's something that I think is very well documented for long-duration spaceflight, that there is an intrinsic change in the architecture of the bone, and it may not fully recover. So some of our questions from a risk management standpoint, and we think about VIIP in the same way, if the anatomy changes and you can't change it back to baseline, but if it compensates properly, are we equal? So there's questions about, is the bone, although different, equally as strong? And you'll see when the eye changes, it may never change back completely, but if your vision is good, it's kind of a neutral impact. And that's our long-term health perspective and tracking. So here's a little bit more detail about the ups and downs, who's going worse, who's getting better. And some of the change we don't really understand. It could be neutral. So you mentioned bone mineral content down, bone mineral density down, which increases urinary calcium, which increases your kidney stone risk. So there's also a picture here where different risks are affecting different systems, and you have to keep your eye on both balls at the same time. Muscle mass, muscle strength, muscle endurance, capillary density. So you can't ignore that the cardiovascular system is taking care of and touching each one of the other systems that we're going to be discussing. And the cardiovascular system is going to play a central role in us understanding VIIP. Neurosensory, you have vestibular disturbances. When they first get on board, we talk about space adaptation syndrome and the kind of nausea, vomiting, headaches, just general malaise. For some people, it's a very unpleasant kind of 48 hours to 72 hours. That can stretch a little bit longer, and we provide them medication to make them feel more comfortable. But it's an adaptive phase where it can be pretty disruptive. I mentioned GI and pharmacokinetics in terms of how the body's absorbing drugs. And so we talk a lot about drugs, but it also applies to the food. So we can give you the right nutrients, but is your body incorporating them? Cardiovascular, a lot of time and energy has been spent on fluid volume, and that's going to become important to thinking about VIIP and thinking about this cerebral spinal fluid in a couple of slides. Orthostatic tolerance, that's one that affects you in a G loading situation. Are you able to stand up and maintain your blood pressure? Are you able to be exposed to a G force and maintain your blood pressure, meaning that you're going to get blood to your eyes, brain, heart, lungs, and function properly? Aerobic capacity. This is one, again, general cardiovascular well-being. Does your heart and the rest of your body function properly to get blood to the muscles that need to move and kind of help you function? We test it at an extreme level because that's the test we know how to do. But it's really about managing your body in an everyday circumstance. So when you come back, if your aerobic capacity is decreased, again, you might be able to walk away, but probably not run away. It's still on the chart, and it's probably still very contentious, is about arrhythmias, how the heart actually beats. But you can see that when you disturb someone's electrolytes and you've changed their fluid status, that, and even your how you're managing something like calcium, which is another ion you'd be concerned about because of the exchange channels and how your heart beats and carries the electrical signal, that we'd be concerned that maybe you're at a higher risk for arrhythmias. The data has been all over the map depending on who's done the study and under what circumstances. Arrhythmias are really hard to deal with in everyday life when you have the best equipment and the most controlled circumstances. So you could see why maybe our questions about arrhythmias has gone unanswered for a long time. But the cardiovascular team continues to pursue an understanding of it. Behavior health and performance, the psychosocial issues, team issues. You're putting folks together in a relatively small space under stressful conditions for long periods of time. I don't know about you, but I don't want to be stuck in a VW bug with my family for 6 months. They're great people, but that's just not really the circumstances you want to live under. But these folks train for it. They go to a lot of exercises. They know what they're getting into. I think the team prepares them well, but you have to understand there's going to be a hormonal response to that sort of stress. And then you throw on top of things like fire behind a rack, equipment breaking down, everyday life. And right now on ISS, J.D. Polk, I mentioned him before, had a great saying. He's like, we used to be able to just confine it to the stresses of space flight and the mission, but now they have a satellite phone and get to talk to their family pretty regularly and hear about the D on the test or the plumbing that broke. And so that in ISS, they can't even extract themselves from everyday life stress in some way. The communication's really good. And while that's beneficial, because they have contact with their family, the downside is you hear about all the hard things that are happening for folks you can't help right now. So the dynamic is incredibly interesting and very complicated. The environment, mentioned a little bit about confined air and water and contaminants in those and how they kind of increase the complexity of the situation. So if you've been to any of our boards, you've heard about carbon dioxide and how we're very, very concerned about the levels of carbon dioxide that are currently run on station and currently planned for future missions. Carbon dioxide is no doubt a very powerful instigator to human physiology, even on Earth. We know that it's not a good exposure. It definitely creates kind of a hostile environment for your body to deal with. It can change the acidity of your blood. It can change your respiratory rate, causes vasodilation, causes vasoconstriction, depending on what organ bed you're talking about. So we'd like to control the CO2 to a level that we're comfortable with which is terrestrial, which is almost, from an engineering perspective in a closed habitat, impossible. So we keep on running this balance of how low is low enough but high enough to allow the engineering to work. And I think it's an ongoing discussion. And you remember OSHA, the Occupational Safety and Health Administration, who helps guide rules and laws about how people work in a terrestrial environment, has really helped set the stage for how we do our SMACs and SWAGs, or space flight allowable concentrations. And the problem is that people work terrestrial on Earth 8, 10, 12 hours a day in an environment and then go home. At ISS, you're going to live and work 7 days a week, 24 hours a day in that environment. So we can only extrapolate or use their input so far before we have to go off and do testing. So the CO2 has been something we've put a lot of thought and energy into and some funding toward to understand better. Acoustics, we do a lot with acoustics, monitoring the sound level. Again, that's very stressful to be in a noisy environment. Radiation exposure, mentioned how much time and energy we put into that portfolio. They've looked at kind of the manifestation of, say, a radiation exposure such as cataracts and cancers. Right now, we have not been able to demonstrate that astronauts have a higher susceptibility or resulting cancer because of their exposure, but we've actually only been flying long-duration space flight since 2000. So it's going to be a lifetime before we accrue enough data to really understand some of those outcomes. We can't compress the time scale for that. We do know that from an immune standpoint and kind of a closed environment standpoint, that we probably have a little bit higher skin irritation and manifestation of skin problems than we'd expect and we're comfortable with. So that's been a topic people have been off pursuing and trying to understand. Is it the immune system that's causing the problem, or is it just high bacterial and maybe microbial growth rates in a closed environment, or is it just that the two systems are out of balance enough that it's both contributing? So you mentioned that we collect a lot of medical requirements data, and that's really this basic set of data that's collected on every astronaut pre, in, and post-flight, and researchers get some insight into that, and they can data share with it. They can actually leverage off of it, and in the ocular health study, what they've done is taken our medical requirement and repeated those measures, augmented them a little bit, but they do it a lot more frequently to build that time course picture that we really need. So hopefully you can see this. This was just an attempt to say, here's a smattering of data that we collect. We try to understand the situation of the crew member from their baseline, their individual baseline, and also from a population, what's going on. I think what's also important to understand, when you look at some of these charts, this is bone mineral density, is the variability. So each one of these little squares is an individual, the dark bar is the average, and that we often have a large spread. That's not unexpected in human data. There tends to be a lot of variability, which is why you usually need such a high N number for the study. But for our work, it makes it very difficult to come to a very concise conclusion very quickly. And this one is actually the pelvis, and here's the mean, and you'll see such a huge standard deviation. So, and this is with countermeasures, and you'll see this is early expeditions when the countermeasures weren't quite as robust as they are today, but the data does not look overtly that different, and we'll get this slide updated for the next lecture. Post-flight functional fitness, similarly. And this is where we're looking not so much what happened to your bone, what happened to the strength of one muscle, but how does your body work in total? So you're looking at push-ups, crunches, pull-ups, sit and reach, bench press, leg press. And you start to see the lower body, we've got some tightness in here. The upper body, we're seeing a lot of variability. This one is actually a test that the NeuroLab does for the medical community. Here is the pre-flight consolidated baseline for the group. Here is the spread. They start out pretty low at R+0 when they return, and this is the recovery curve. I believe this is the 95% confidence interval. So you see everyone trending toward recovery within the first week, but there's a lot of variability about where people come back toward baseline. And this one, we've talked to the docs quite a bit. We've tried to understand for any one of these medical requirements, how is the data really used and how do we interpret it. This is one of those that is actually kind of a sanity check for both the doc and the crew member. Because again, I mentioned that they can look really good and they can kind of hold it together when they're in your presence. But when they're perturbed, and this test is designed to be provocative, it's going to have you close your eyes, it's going to have an unstable platform on your feet, and then at one point they even ask you to tilt your head back, and that's very provocative for your inner ear when you lose your ability to use your eyesight, and also you change the gait of your feet, and they're harnessed to protect them, but they're going to tip over. So again, if you were walking on a sidewalk, you were distracted, looked away, and your feet were unstable, you have a very high likelihood of falling down and hurting yourself. You fall down, you hurt yourself, and you have low bone mineral density in your hip, that results in a bad outcome that wouldn't normally happen in a 48-year-old male, but we've had it happen. This is actually the bone mineral density one, quite the variability. We've actually seen better returns, obviously, with the advanced resistive exercise device when you create a loading environment. But another thing to remember about countermeasures, and when we talk about VIIP, we have to kind of think about the inverse. But countermeasures can only be provided for a small amount of time every day, right? Normally, we're exposed to gravity 24/7 in some vector. A lot of it, in line with your body so that your bones, your skeletal structure is loaded vertically. But you get up, you pick up your bag, you transition to your car, you take your groceries, you take your kids, whatever it happens to be, lugging around your laptop all day. Well, for about 23 hours a day, people on ISS are completely unloaded, and we only add it back for an hour. So that's that's not a lot of loading considering how much they're offloaded. So really, I always thought of it as we're just buffering the loss. You're never going to stop the loss completely. But some of the data from ARED has been pretty impressive. With VIIP, I think you should remember that we're only providing countermeasures if it is a negative stimulus for small amounts of time every day. It's not like we're continually being provocative to drive VIIP if countermeasures were involved. So we've had lots of questions about the role that they play, and it's a cost benefit. If we thought VIIP was a worse enough outcome to take away something like the resistive exercise device, well, we lose the bone mineral density that we gained by having the resistive exercise device. Which system are you going to pick? Obviously, they're both important, but they're probably important in different aspects of the mission. You need your vision now to perform your mission, especially if there's critical ops and you need to read procedures. You don't need your bone mineral density while you're in zero gravity. You need it later when you come back in a gravitational field to protect you. So it might be, when do we need one? I'm particularly thinking of like a Mars type mission when I'm going to have to choose between systems, or which system do I need to optimize now versus which can I fix later. So this was another one we threw in to help illustrate the complexity and the level of detail people are looking at these different systems. This was one I mentioned that we're not only changing the density, but we're altering the architecture of the bone, how the trabecular bone actually interfaces with itself in the trabeculi. And when those trabeculi actually lose a connection, you can't get it back. And that's the reason why, even though you can get recovery post-flight, the bone on the inside will never look the same again. The bone deposits more density along the shaft of the bone, the cortical bone, so we have questions about, is the bone equally as strong? Because that ends up being the end metric you're interested in. It may always look different, but is it equally as functional as it used to be? So there's been some studies funded that take cadaver bone and test it and see how much force you can exert on it before it breaks. Because some of these tests, and especially when we're dealing with kind of designing our requirements, we won't take the human to failure, right? That's not going to happen. You need some precursor marker to help you understand where this thing is going. I actually can't have the bad thing happen to say that was the limit. I have to pick some previous part of the curve to make that decision. You're going down this way. So I always think of the tilt test, which was testing orthostatic intolerance, had good termination criteria. If you have an increase in heart rate by this many beats per minute, a decrease in blood pressure by this many millimeters of mercury, test over, because I know you're going to pass out, but I actually can't let you go to syncope to be my end measurement. I just know you're going that way. Bone has similar kind of characteristics that you can measure that say they're trending toward a bad place. I think your fracture would be imminent. What's interesting about fracture and where we've really struggled is it's not just the bone that's playing a role, it's the force exerted on it. If you can avoid a force, you can avoid a fracture. That's not realistic, whether you're on the surface of Mars or the surface on Earth. You're going to incur forces, both vertically, laterally. You're going to lean on things, you're going to trip, you're going to go upstairs and come downstairs. So the deal is we're going to have to get the bone density to a place that we're comfortable that we've managed the risk as appropriately as possible. So of course we do the research in analog environments. We have, I think, a lot of healthy debate about the role of any one analog, how far you can take it, which systems is it appropriate for. And that's why I think we have a variety of different analogs available to us. We can't recreate microgravity here and control for all the other things, so we kind of test one or two systems at a time in the various analogs and then try to put the pieces back together outside of it. Of course, we have the operational countermeasures we talked about along the way. We also have, for any given person that we have data on, variable access to the countermeasures. This is an older graph, but this is the way its capability is tracked on the hardware itself. So when we talked about layers of complexity, you have devices and exposures, and you have data on a person. Well, you might be able to collect the same set of data, but the circumstances under which the data was collected on the other person are completely different. So again, that's going to tell you that you probably need more N number than you even started out with, because the variables that you can't control for are changing. Okay, so the meat of the talk. What is the visual impairment and intracranial pressure issue? So the facts of it are, it is optic disc edema, it is globe flattening, it is choroidal folds, it is a hyperoptic shift, and in a few people we've been able to demonstrate raised intracranial pressure. Not in all. The reason we don't know what's really happened to intracranial pressure is that it's an invasive test. The other things we've documented are all done non-invasively. So the risk you're taking with the test itself is minimal, right? There might be some exposure if you're using a radioactive form of imaging, but in most of our cases they're non-radiation imaging modalities. In the case of intracranial pressure, you're going to use a needle to puncture the spine, to get some fluid to go into a column, and use a manometer to measure the pressure. When you do that, you incur risk. It's higher than venipuncture, which is taking the blood, say, out of a vein in an arm, which we consider reasonable when you're doing tests and need blood as your constituents. The intracranial pressure has been very controversial because there's not a low-risk way to get it right now. We've spent a considerable amount of time and energy trying to find a non-invasive device and have not been very successful. We've tried to partner with a variety of different groups terrestrially in terrestrial medicine, because there are people with a disorder called idiopathic intracranial hypertension who need repeated lumbar punctures to measure intracranial pressure. Every time you do a lumbar puncture, you have a reasonable risk of headache. You also have a reasonable risk of infection. And it's one of those things that we haven't felt that the benefit of the information outweighs the risk of the procedure. So on the operational and medical side, we have not been able to come to agreement that this is necessary on every crew member. So it's only been post-flight when someone has shown, I'll say, extreme symptoms, like a high degree of optic disc edema, which is measured by an optometrist or ophthalmologist on what's called a Friesen scale, or that they've had demonstrated choroidal folds, headache, which has been very few of related to this. Now, the CO2 headache is a little different, and they can be a little confusing at times. But when someone has enough symptoms post-flight, they go and get a lumbar puncture. So you get a number, someone has symptoms, the physicians interpret it, they have treated on occasion with a particular medicine that is thought to be helpful. It's not always helpful, and there's another risk associated with the medication. But the problem is we don't have a pre-flight number to know the change. And the numbers have not been excessively high. And so I'll give you some numbers for context. In idiopathic intracranial hypertension, when an individual has really overt symptoms and seeks medical help, the numbers can be in the 50s and 60s millimeters of mercury when it's measured. Normal ICP is less than 15 millimeters of mercury. And there'll be people talking about, well, were you on the left lateral decubitus position? But in general, 15, if we measure everybody laying down the same way on their left side, about 15 is what you would expect. They think when you go vertical, it should go lower than that. But we're going to tell everybody to be on their left side. We've seen people around 20, 21. I think we've seen it as high as 28 on occasion. Those numbers are high, not alarmingly high. And also the disconnect has been when we've met with that research and clinical advisory panel, the numbers have not been high enough to say, I would have expected to see that anatomical change in the back of the eye. So they feel there's a bit of a disconnect. Well, there's also the statement that we have no clue how high it goes in flight, right? We have no data on ICP during a mission when they're exposed to microgravity. We only have it post-landing, and sometimes days to weeks post-landing. So there's questions about, well, maybe it's excessively high in flight. What's interesting about that, and that could be true, Dr. Otto is working on a hypothesis related to that, is that they're not having the other symptoms of high ICP. So when your intracranial pressure goes really high, you can imagine you get a pretty bad headache. We don't have people having incapacitating headaches. We have people having annoying headaches. We have them having headaches early in flight with space adaptation syndrome, could be ICP changing. We have people having occasional bad headaches, and then we go back and try to track down the environmental data, and we found some high CO2 related to headaches. So that's another kind of confounder rolling in there. But we don't have people, if they had consistently high ICP, we don't have them having these incapacitating headaches. So the outsiders, those RCAP folks who've been helping us, have agreed that it's very confusing. The data and the observations are very confusing. So there is, I think, a considerable amount of energy, work, and debate going into measuring intracranial pressure directly during a mission. There's some options to do that, but they are all relatively high risk. So at some point, yes, there's a question in the back.
I was just going to ask, when you say we have no data from in-flight, do you mean through the more direct, invasive methods?
Yes.
So not counting the OCT and sort of the
Right. So I'll get a little bit further into this. I tend to talk on one or two slides quite a bit, but the other ones are indicative. They're like inferred ICP. If you think ICP is driving the mechanism of why the swelling is occurring, and there's some data, there's terrestrial work that relates optic disc edema to ICP or lack of venous pulsations to ICP. But it's a relationship between the two things that allow you to make that statement about changes in ICP. When we look at one of those variables, like the disc or the fundus, we're not sure we know what the other thing is. We're not even sure we know where it's starting. So you could infer, and I think it's legitimate to think ICP is involved, but how high is it going and why the anatomy seems to indicate really high but other symptoms don't is a little confusing. So I think the RCAP has been like, you just don't know. Go measure it. well, go measure, it's a little complicated. So we haven't gone there yet. So we don't have that data.
Time course on this in terms of like the chart that you showed us.
Yeah.
Your graph. Good piece of course.
So the manifestation, the time course of the manifestation of the optic disc edema. Yeah, so from an ops perspective, we were taking data points about 3 times in flight. At the first 30 days, around the 100-day mark, and about 30 days before landing, we were getting data. So you had 3 data points to look at optic disc edema, to measure eye pressure, and kind of, so you had a little smattering of time course data. The ocular health study is filling in a lot of those gaps by taking the data more frequently to say, okay, when do you really see the optic disc edema manifest? And do you see it worsening? So what does the curve look like? And I think that's what they're building right now.
Question.
Sure.
You mentioned about the space adaptation period. So during that period, do all the crew members have a high ICP?
Well, we don't know anything about ICP. We think during space adaptation, what we know is observational in terms of their reports of nausea, vomiting, headache. And that's consistently, I think it's about 80% of long-duration crew members have those symptoms for the first 48 to 72 hours. And you'll get a few outliers here and there, more days, more severe, but that's the generalization.
So for those who have those vision impairment issues, it goes beyond those 72 hours?
No, so interestingly, when we have LSAH, epidemiologists and biostatisticians who probably can speak a little bit more clearly, when we've gone back and tried to map the data of the outcomes, what we've measured from an OCT, fundoscopy, when we've classified people in terms of VIIP and said, have they had worse space adaptation syndrome or space adaptation syndrome longer, there's not a good mapping. There's not a correlation. And that there's also, confusingly, and I'll get a little bit further into this, this is just some history. There is not a good correlation between functional outcome, meaning visual impairment, and also these anatomical changes. But the eye and the brain are very complex. And again, there's lots of things that compensate, and some people apparently are better at compensating than others. So you won't see people with the worst functional vision change have the worst swelling. That's not a true statement right now, interestingly enough. So from a historical perspective, really we changed our behavior operationally in 2008. You say, okay, well that's 6 years ago now. We've been able to get fundoscopy and eye ultrasound data since 2008. Not regularly, not for the same scheduling, but that's when it all started to be put in place. I think it was really 2010 when things became much more regular. Remember, we also, on the ops side, are treating them as individuals, not just as a population. So often you're doing things that mean something for that person and the symptoms they're having, and trying to understand if is it just true for that person or is it something I need to apply to the bigger population. Of course, the Sentinel case was found earlier than 2008, but that was based on us understanding things and looking retrospectively. At the time, that person was just being dealt with as an individual. Really, it was 2010 when we did the much more integrated approach where we have the research side of VIIP and the operational side of VIIP, and we try to make sure there's good communication between the two and that we move information between the two groups as regularly and as quickly as possible. We don't wait for the research side to fully publish and vet everything before the operational side knows about it. They're working much more closely hand in hand. Of course, we have the research and clinical advisory panel. And they also started funding 9 studies in 2012, which you know means if you get funded in 2012, your money probably shows up in 2013. If you're a flight study, you're not collecting data for a couple more years. If you're a ground study, you might get kicked off in 2013. It's only 2014, so people are just, probably the ball is really getting rolling on data coming in and being analyzed. Ocular Health had a bit of an edge because they were using the medical requirement as their base, and also were able to accelerate things because operationally we felt really strongly it was the right thing to do. So when you talk about CPG classification, that was our way of saying levels of severity. And it's kind of a mixed bag of things. So tried to understand the refractive change. how bad did your functional vision get and how quickly did it get there? And then with respect to the functional change, what happens to the anatomy? Because sometimes there was no functional change, but the anatomy was looking pretty swollen and different. And it was interesting that the eye was able to compensate and that the vision wasn't getting really bad right then. But you'd say, are we causing permanent damage to the back of the eye? Christian Otto, I think, has talked quite a bit, and I agree with him that there's a lot of concern when you put tissues under pressure for high periods of time, you start doing permanent damage. So the body can only tolerate that for so long before it's going to start to remodel, and that remodeling may not be able to be undone. Interestingly enough, where the optic nerve intersects with the back of the eye at the optic disc, the way the cells are layered, on the periphery there's very few cells, like say 2 cell layers deep. And from us scouring the literature, it's your peripheral vision that's going to manifest the problem permanently. Because when you start killing off those nerve cells, since you're only 2 nerve cells deep, you're at a 50% loss at one point. What's interesting about peripheral vision is it's not obvious it's getting bad. We talk about behaviors. Well, if you can't see something in your periphery, you turn your head. So you have to do a very specific test to get someone to lock their head in a certain position and test their vision when they can see. Obviously, if you're with a doctor, you've seen them, they're going to bring their fingers into your eyes. There's actually a machine that can help us do it called perimetry. It's a relatively large piece of hardware because you figure you got to wrap kind of around yourself. And we've been trying to work with a group to get a smaller, more spaceflight friendly device up there, but nothing's at the level of maturity we're ready to fly yet. But we think it would be the peripheral vision that would take the hit first, not your central vision. So right now we have 4 classifications. Interestingly enough, you talk about all the N number we have. Well, we lack a certain amount of data that we can't even evaluate some folks. So we'll have functional vision data. They went to the optometrist and had their vision tested, their eyes tested, and their general eye health categorized. But they didn't have OCT. They didn't have fundoscopy. We don't have the MRI of their eyes. So we really can't classify them. Do we know absolutely it wasn't happening? No. So it's really not fair to put them in the bucket of the N number because they're unknowns, they're not zeros. So we've been clear that 0 is an important number. Knowing someone didn't have a bad outcome, knowing they didn't manifest any symptoms is a very important data point for us. So zeros are real, no data is no data. So this was kind of the spread about a year and a half ago when this talk was given, and the numbers have shifted around a little bit. Also, remember, the classifications are going to change. Our opinion of what's severe could be altered as well. So this was something that's a very man-made structure just to give us some information and be able to gauge what's going on with the crew members. And also to understand what we really consider severe. At some point, some of the anatomical changes could go by the way of other things and said, okay, it's a fact, it's documented, but it's not necessarily a bad outcome. It's a change due to spaceflight. But the long-term health implications are going to take a while for us to figure out. So acutely, this is kind of our picture on this levels of severity, with class 4 being the worst. So really, it's a 3-part story, right? We talked about a lot of different elements of physiology and spaceflight. And so you have to consider the whole vascular system, how it's functioning, how it's managing fluid, how it's managing pressure. It can dilate, it can constrict. It's affected by both your gender, your age, other genetic components that we don't really understand, but are running around in the background. The brain itself. So interestingly enough, we'll spend some time talking about cerebral spinal fluid production, your brain's ability to clear it, and the venous system, which is an instrumental part of the drainage, which might be affected by spaceflight. And then you have the eye itself. It's a whole nother compartment. It has to deal with fluid inflow, fluid outflow, pressure changes. And we've had some interesting presentations by folks who have now talked to us about the optic nerve. And basically, it's not a Bernoulli's tube. It's not a hollow tube containing the nerves. It's not a straight line. It has a lot of microarchitecture itself. So if fluid is transduced down that tube, it may get stuck there. So what's interesting about the eye, when that question was asked earlier about what we see in the back of the eye, and is it telling us something about ICP? It might be telling us something about the local pressure environment, not the whole brain environment, which is important to consider, because people have questions. If you put the whole brain under pressure for a long period of time, are you going to drive problems with cognitive function from an immediate perspective? And then we've even had questions about, you know, your long-term cognitive health. Would you get early onset dementia or senility or something because of the spaceflight exposure for 6 or 12 months? We can't answer any of those questions, but they've been out there and they've been asked of us. So most of you are familiar with the fluid shift. You go into microgravity. It's a little bit more extreme than what you experience when you lay down in bed at night and go horizontal. You tilt a couple liters of fluid towards your head. A lot of pressure sensors reside in the upper part of your body, so they're going to respond to that shift, and they're going to allow you to diurese some fluid off. They're going to recompartmentalize some of the other fluid. So in the end, the net effect is you're going to be down total blood volume when you're in space, but you're considered normovolemic for the environment because you don't have gravity pulling blood towards your feet. It's not locked away in your venous system or in the interstitial space in your legs and your lower body. So you have enough during a normal activity. What's interesting, as we mentioned before, with aerobic capacity is down. Well, when you activate a large group of skeletal muscle when you're exercising, it's going to need a lot of volume of blood to feed that. You got to get oxygen to that exercising muscle. Well, you probably don't have enough volume to accommodate what you did on the ground. So I think it was not a big surprise to say that your aerobic capacity was reduced, but it doesn't mean that your heart beat any less hard or your muscles were weaker at the time. You just might have less fluid to feed them, less oxygen carrying capability. The other part of this is when you go into a gravitational field, like when they return and why they have intolerance, is your blood vessels also are very smart in that they're not going to do things they don't have to do. So they're used to dilating and constricting on an as needed basis when you get up and down during the day. You're laying, you're standing, you're sitting. It's a very dynamic postural situation. Well, in spaceflight, you haven't had a lot of that dynamic situation for long periods of time. Your body doesn't retain a capability it doesn't need. It can learn it again, but it doesn't have it instantaneously. So you return to a gravitational field, a large amount of blood volume is pulled back to your feet. Your veins are very compliant. They'll dilate out, fill up like a bag. They don't exert a force back yet. And then also there's a Starling equation that tells you when you're going to leak blood out into the tissue. When you leak blood into a tissue compartment, it's lost. It can't get back in the vascular system. It's drained off by the lymphatics. So when we talk about how this whole system is working with respect to the head, in space you have the inverted problem. It's like standing up when you're in a 1G field. Going into microgravity is like hanging upside down on your monkey bars to a degree. It's a little more than 6 degrees head down. They've done some tests, and we use 6-degree head down in our analog bed rest studies, but being in space is a little more severe than that. So you get this volume. Well, now the blood vessels in your upper body have to deal with this volume they're not used to dealing with, and blood leaks out. Tissues get swollen. Also, if your venous drainage isn't working properly, let's go to this one. If your venous drainage isn't working properly because the venous system is overwhelmed or has nowhere to drain to, which is kind of the thought process at this point, you have a back pressure on the system. So just from kind of simple plumbing terms, blood's still coming in, blood really can't get out, the space in the middle is going to get engorged. Well, the space in the middle happens to be your brain. Your brain is in a hard case, but your eyes aren't. So I've always thought of your eyes as kind of this little pressure relief valve to a certain degree. What's interesting is also inflow. Arterial inflow to the brain is a driving force for CSF production. The venous outflow is a significant part of the drainage system for CSF. Well, if venous outflow isn't so good, you've also got CSF accruing. So you have blood volume accruing, you have CSF accruing, and you got your brain in a hard case. Well, when a tissue swells, it also causes a compressive force on the blood vessels that are in it, which will decrease the venous outflow as well. So it becomes, when you get swollen tissue, you get a bit of a vicious cycle going on. And so when you think of the back of the eye, and the eye has its own separate blood flow from the brain, that the same kind of system is set up there. So we started talking about you have inflow, lack of outflow, tissue swelling, external compression on the same venous system that's already having trouble flowing out. So again, a little bit of a vicious cycle going on in the back of the brain, in the eye. So this was just to demonstrate what we think we have in 1G. You can get negative pressure up in the head. That's what your body's used to dealing with. But in microgravity, it goes positive. Well, that's not something your body can deal with pretty quickly. It'll adapt, or it'll remodel, and it might not be to the benefit of the organ, but it's something it has to do from a physics perspective. So, when we talked before real quickly about what the characteristics were, so here's the actual picture of the eye that we use to talk to folks about it. So you have the optic nerve coming in the back. This is the optic disc. You have the choroid lining the back of the eye with the retina. Now, everybody's eye shape is a little bit different, right? And between the shape of your lens, the shape of your eye has figured out how it's going to see. Some of us use contacts or glasses to help it see more clearly, but it's that focal distance from the back of the eye to the lens that's determining how your eye focuses on an object. Well, when your eye swells, it actually becomes more flat. That's that globe flattening effect. We have two ways the globe can become flat, and this is something Dr. Sargassian has talked quite a bit about. The choroid itself comes forward, so if the eye is concave, as it swells, it comes forward, which changes the focal distance. And then as the optic nerve gets swollen, it pushes the eye forward. So you have both the spherical shape of the eye is changing, and then the inside of the eye shape is changing, coming forward. So we've had people have both choroidal flattening, globe flattening due to choroid engorgement, and also optic disc from the optic nerve coming forward. And so we've tried to understand the difference from an ICP, what's going on in your brain side, of saying that's probably pushing the optic nerve forward, whereas the eye itself, when its venous flow is obstructed, that's probably the choroid coming forward. And we see components of both happening in the astronaut's eyes. When the choroid gets swollen, I mentioned before, it's in a certain volume. Well, in order for a tissue to take up more space in a given volume, it has to invaginate, it folds on itself. And from an OCT perspective, the optical coherence tomography, when you take that, you can actually see a topographical change in that it becomes wavy. And on a fundoscope, it shows up as striations. It looks like lines. And those are essentially become scars. They never really go away. So that's something we've said historically in astronauts we can go back and look for at least to see if there's evidence historically for those people we didn't have all the images on, do they have choroidal folds. Another thing that's important about choroidal folds is it's not a normal product of aging. It's something you would see due to choroidal engorgement, which is pathological. And that's something the RCAP has felt really strongly that we go back and document historically. So as we bring the astronauts back for their annual exams, we've kind of augmented the visual tests that they get the fundoscopy done. We would like to get MRI done. But the deal is resources are constrained, money, time, all this planning. So stepwise changes are being made in the annual exams. For the astronauts who flew long duration, who are still part of the Corps, we have a little bit lower threshold to add those tests back, but we're trying to get everybody back in and document at least to see if there's choroidal folds there. The optic disc edema, that's the one we're concerned about affecting acutely the peripheral vision. And it could get as bad as, you start to see decrements in your central field of view. So something else you'll hear about when you talk about VIIP, that's which one of these does not look like the others? And when you talk to the RCAP, particularly Andy Lee, a neuro-ophthalmologist who's downtown, when he comes in, this thing called a cotton wool spot, which is seen on the back of the eye via fundoscopy or OCT, it actually can be demonstrated, is a very different marker. And we've seen a couple of those show up. Sometimes they've shown up post-flight. They haven't always been there immediately upon landing. They've shown up days to weeks afterward. We don't see a lot of them, but it's actually a vascular infarct. It's when the blood vessel actually lets loose and there's like material that's collected in a certain area and it makes this opaque little mark on the back of the eye. So we don't exactly know how that fits into the scheme of things. We track them very closely. We look for the resolution, but it's one of the more serious markers of swelling and pressure in the back of the eye that we're concerned about. But it's not directly related. We've had people have, Friesen scale 3 optic disc edema. We've seen them have pretty severe choroidal engorgement, and they never get cotton wool spot. We'll see somebody who had what we thought were the minor symptoms, say they were CPG1, and they'll show up with a cotton wool spot. And that goes back to an individual's tissue compliance, that some people can tolerate very little change in pressure, other people's tissues can change a high degree of change in pressure and not manifest the same pathology. So within this small population we're working with, a lot of variability is going on. So it's hard to draw those direct conclusions, say, okay, well, if I see this degree of choroidal engorgement, I think ICP went up 10 millimeters of mercury. If I see this degree of optic disc edema, I think ICP went up 20 millimeters of mercury. It's not that type of linear relationship at all. So OCT and the on-orbit measures, whether it be fundoscopy, ultrasound, have really given us a lot more insight into the eye. I guess that's one of those puns. We've had a hard time getting away with them from VIIP, but it's also amazing all the data you can get, and it's also amazing how you have a really hard time interpreting it. So right now, I go frequently, I guess, to the ISS program. I was there a couple months ago at their Probable Risk Assessment Board, the PRAB, to make the case for why we have this risk, why we spend this money on this risk, why we have this hardware, what is it telling us? And then the question is, well, when are you going to fix it? When have you solved it? And I was like, we're not quite there yet. We're still kind of in a characterizing phase. And they were very sympathetic to our cause. They understand that we're still trying to get our arms around this risk, and that it's more about spaceflight physiology and in total what's happening to the body you sent and how different the bodies are, but that when we try to give a program some risk feedback, that we're not as crisp as we'd like to be, but we're still trying to refine which data matters the most. They're going to ask us at some point on ISS to pare down what we do. Which is more important, fundoscopy or OCT, or ultrasound, or tonometry, or, and so we go back and we work with our EPIs and biostatisticians to say which pieces of data have been most constructive in us kind of parsing out the groups, which ones have matched more closely with functional outcomes. And at this point, we haven't amassed enough data to be able to make those conclusions, but that's the goal on the ops side. And the research side is just continue to augment that. The research side also helps us ask more questions. We say, like, when is your study going to produce results? Well, it's like, well, if you consider 20 more questions the result, I think we've been very successful. So it's not always that you come up with the answer. It's just kind of moved you in a direction more toward the answer. I think we know which direction we're going in. We're going all one way together instead of kind of being on different sides of the fence.
What about the exercise groups? Do they have some exercise that can accelerate the drainage of the lymphatic?
So you would think that if you activated a large group of lower body muscles, actually the one that came to mind as you were asking the question about an exercise that could increase venous drainage, it wouldn't be an exercise necessarily, but you could mimic it. It's lower body negative pressure. If you pull the negative pressure on the lower body, you could increase venous drainage. So one of the pieces of data that's actually been really interesting, let's do a little time check, is that back in the shuttle days, they measured central venous pressure on a couple subjects. They were instrumented. It was very controversial at the time. Ben Levine, I think, was the PI. And they were expecting central venous pressure, I'm trying to think what the expectation was. I think they were expecting it to stay the same or go slightly positive, and this is a very key statement, where they measured it, it went slightly negative. And they were like, that's why no one thought there was a venous drainage problem. Because if you measure venous pressure at the right side of the heart, all the blood dumping into the right side of the heart, well, you would think it's like a waterfall effect if it's zero or slightly negative. It's almost a sucking force, like a siphon, right? Well, there's been a lot of debate about the location of where that pressure transducer was when they got that data in shuttle. So, and now Dr. Levine has spoken about that a couple times, and he's not so sure it was exactly where they thought it was. So there's a
Question. Now, if you look at the whole body physiology, there were some risks, the high lipids,
Mm-hmm.
and the fasting serum glucose and all of that.
Yes.
Now, would people at risk or who already have those risks be at increased risk for this at a shorter time point, having those impaired functional defects? Are you looking into those things?
Yeah, so the question is about kind of your, all of your cardiovascular risk factors such as lipids, C-reactive protein, your HPLC, is it like body fat, your BMI. So actually, Dr. Cristianato has been putting together, I think leading the effort, there's been a large group of people involved, at looking at those risk factors. The last I heard and saw the data, there is a trend that people who are higher, whether it be, I think there's a group of factors such as blood pressure, the lipids, I'm looking at Millennia.
So if they have worse cardio risk factors, they're a worse case, but it doesn't separate the cases from the non-cases. Just if you're a case, you're a worse case.
Yeah, so in the spectrum of things, and that kind of speaks to the compliance issue. And we know terrestrially that if you have poor cardiovascular compliance, you're at risk for cardiac events, whether it be heart attack or stroke. And those are all the piece parts that lead us to believe why you are less compliant, because usually you don't have nitric oxide. You've destroyed your endothelium. So I think those same rules apply in general, but it's not deterministic.
Yes, we can't.
Right. So you can't. So people want to go toward, do you have a selection criteria? Yeah, exactly. So they haven't quite parsed themselves out that cleanly that you could justifiably make a selection case at that point. But we could inform someone they are higher risk for this if they have these risk factors in place. Interestingly enough, as you can imagine, we keep the astronaut corps very healthy. I mean, we are responsible for their everyday health and well-being while they're in the astronaut corps. We manage these risk factors as best as possible. So within a very healthy group, you're going to still have a spectrum. So those that are on the higher end of the cardiovascular risk factors within a very healthy group do run a higher risk. So good point. So when you talk about what does all this matter, if it's anatomy changing, if it's spaceflight physiology, this stuff is kind of rolling around in the background. The rubber meets the road when you can't see something, or you can't see something coming, or you can't read emergency procedures, or you can't differentiate between a couple of buttons on the return. Like that, this is where it matters that your vision has been impaired. Why your vision has been impaired matters to us, because that's where we get to interfere with the process. That's where we either get to deal with the selection issue and not choose someone who's incredibly susceptible, or we can't manage the risk. We get to use countermeasures to interfere with the pathological process and prevent it from getting worse. We can provide other countermeasures like glasses if we know that your vision is impaired, and that's actually what we do right now. That's actually listed on our risk as one of our mitigations. We know going into space your vision is going to be altered slightly. There's like a 95% chance it'll be changed, and we send them with cheater glasses. We actually have very expensive glasses that you can dial in a new prescription, but they don't like wearing them because they're ugly and they're expensive. But so they wear like the $2 ones, just the reading glass, and it's fine. It works. And not everybody who has a functional vision change actually has really bad pathology. So it's a reasonable and doable mitigation, which we accept. However, if we know there is a pathological process behind it, we need to act on that. And we're trying to understand it so we would actually know to interfere. I mentioned before that there is a medication that you can give that some percentage of the time, and it's pretty low, it's probably around 20% when we deal with the Idiopathic Intracranial Hypertension Society. The medication only works about 20% of the time. And they're actively looking for something to help manage high intracranial pressure pharmaceutically. They just know they haven't been very successful at it. So we've used this medication post-flight because there's always a risk profile associated with a drug. And because it's so not dependable in terms of it working well, we've been very reluctant to ever think to use it on orbit. It's one of those that it would be a last-ditch effort to try to get somebody's pressure down. It's called Diamox. You know, it's an old-school drug. It's a very dirty drug, meaning that it has lots of side effects. So you may get the side effect and not the prime effect that you're looking for is actually more likely. So it's around, it's just not very effective. So we're off, you know, just looking, doing market surveys, tech watch to see what's out there, and hopefully something better will come along. But it would not be our preference to go pharmaceutical. We would want to use another way to get there. So we talked a little bit about the key areas of the brain. I think Christian would be much better poised to go through this mechanistically in terms of the choroid plexus and how much CSF is produced and how it bathes the brain and the spinal cord, and if you were to interfere with that process or the outflow, you know, how that's affected. They even think the arachnoid villi, there's actually some interesting animal data that looked at the brain of rats who were flown or mice who were flown on shuttle that said the arachnoid villi are actually affected by microgravity exposure. So there's some discussion that it's not just a blood flow issue, that it's the brain itself is having some issues with CSF production. And the feedback loop, when enough CSF has been produced, is interrupted, so it continues to make CSF even when there's plenty. So we have some questions about that. Our MRI data pre and post flight seems to indicate there's some disruption in the production, and we measure it by flow velocity, so it's not a direct measurement of the arachnoid villi, but it's getting us to where we think that's also a player. In which crew members is it a player, to what degree is it a player, all unknown. Again, we mentioned that between the CSF production, the brain itself and the hard case and the venous system, there's a good picture here actually on this MRI, and actually I think this is a like an angiogram, but you see this depression here, that's actually the vein, this vein being pinched off. And what can happen is, when we talked about when the tissue becomes swollen, when the fluid actually leaks out of the blood vessels and into a tissue compartment, in this case the brain, the tissue itself impinges the blood flow. Well, that's the exact thing you don't want to happen, because that's your outflow source, which will cause more backup pressure, more leakage, more swelling, and that's that vicious cycle. So they've been able to demonstrate this in the brain of people with IIH, and this is something they would go in and they stent this open. They use a metal mesh. The problem is that the brain will collapse that mesh over and over again. So they know they replace them pretty frequently. As you can imagine, that's not desirable. There's another picture of just how the venous structure is on the back of the head. So you can see how large these vessels are in relation to the brain. So that if you impinge either on either side or both sides, you're going to have quite the pressure change inside. And this is just our classification system as it currently was, I think, about a couple months ago. We've updated this based on current data and kind of shifted some of the categories. It can be very subtle. And that's another thing that's challenging to anyone doing the statistics, is that when you change your categories, so you would almost have to go back and recalculate everybody and reclassify them. Radiation modeling has a similar issue in that when their models are updated, you got to take all the data that was used in the prior classifications, put it into the new model, and then the people are reclassified again. So this is just something that you got to keep track of. It. Even subtle changes could mean a lot in terms of how we're classifying folks and what the classifications mean. So this is kind of a graphic to demonstrate where our medical requirements sit, and then where ocular health, which is a study, sits, and how it augmented what we do a little bit. So the pre-post or the pre-flight exams, we do them twice. You want to get the same data twice pre-flight. These are systems that are affected by everyday life. So you just kind of want a reality check closer to pre-flight when we get ours. So we get them way out at a year, because we do a lot of screening that says you're ready to go for your mission, you don't have a brain tumor, you don't have an aneurysm. That's the sort of thing we're looking for at way out here. Closer to flight, this is where we're trying to understand what is your visual acuity before you go into space? What is your intraocular pressure before you go into space? And then we check it at L+30, around the L+100, R-30, 30 days before you go home, because if there's anything we need to be wary of, any special preparation we need to make for landing, any special accommodations we do on orbit, we need to know about a month before you come back. And then we do the testing as soon as you return. It's R+1 because we have people flying back directly from Kazakhstan to the United States, and it takes them about a day to get here. So we don't, there's some work now with R+0, like doing work in the tent, characterizing them, taking some data. The docs are there to take care of them medically, but in terms of, very sensitive and specific testing, it isn't done until they return back here to the quarantine facility. All of the green markers are where the ocular health study does the same data takes, but you see how much more frequently. So they leverage off of our pre-flight data takes. They take more in-flight, and they take much more post-flight to kind of build that time course and look at the resolution. They also augmented what they do. So they do all the same stuff the OpSci does, and then they do some more because they wanted some more specific data. And they also had some more questions. And these were things that we couldn't always justify on the medical side. There is a line between the clinical side and the research side, right? When we make a medical requirement, it's mandatory, so we better have some good rationale for why we're making it a requirement. On the research side, it's voluntary, so you might have some questions and not really know what the answer is going to be or what you're going to do with the data, and that's okay, and that's what you're telling people and why you're doing the work. And the feedback should be once you do the research side and you build the evidence base, we transition that back to the ops side. So either we're going to do more or we're going to do different. We could be more sensitive or specific, but you would be, on the research side, would be building the evidence base for how we interpret it as well. What did that mean when we saw that on the image? What did it mean when you found that outcome on the blood test? So what we're really concerned about, obviously, is really the disability. I mean, both acutely in the mission, how are we affecting them functionally? We can't always tell you that the change in anatomy is harmless. So what is this disability we're inducing? And vision loss is the most obvious one, but cognitive function is rolling around out there. But it's actually very challenging to measure changes in subtle cognitive function. You're talking like 8 hours of cognitive testing to get at the level of sensitivity. And these are obviously very high functioning people, so a small percent decline may be hard to measure. And so when we've talked about it, it will be a research study and a very large undertaking to look at the cognitive change, because we don't see it overtly. There's no obvious thing for us to point out. You'll hear kind of commentary about the space stupids you might have heard, but you're under a high stress environment on any given day. You have a lot on your plate. The schedule is packed. That can be overwhelming. There's lots of reasons why you feel cognitively you're not up to snuff. So it doesn't mean that you've got irreparable brain damage. It just we may like to use that excuse, but it could just be real life. It doesn't mean that VIIP is causing cognitive impairment. Potential for long-term sequelae, meaning have we damaged your optic nerve to the point of where it can't be repaired and you have permanent damage, vision loss? That would be that peripheral loss, not just central loss. The effect on the white matter, the senility, the dementia. So that's not just in-mission cognitive effect, which could be acute phase and maybe you recover. We've had a lot of questions when you've had the brain under pressure or change for significant amounts of time, 6 months, 1 year. Have we induced a long-term health risk that we didn't previously have? And so I know, again, I'll point to the epidemiologists and biostatisticians. That'll kind of play out over time in terms of do these groups of astronauts who are exposed to this look different than the healthy general population? Are they experiencing these symptoms or outcomes sooner in life or to a worse degree in life or more frequently in life? And some of that is just going to take us time to figure out. Again, we can't accelerate that. And then, is this really part of space adaptation syndrome? Is this the early changes that we were describing in terms of pressure in the brain? Is that really what drives the motion sickness? Is that really space adaptation syndrome? Is that all part of the same thing rolling around? We have different names for them now, but is it really? VIIP is the other side of it. Space adaptation is the early thing. VIIP is the later thing. I don't know. That'll be something we have to put together over time together. Now the question becomes, could we make this worse with repetitive flights? Back to the kind of the selection, retention, certification points. Do we understand repetitively what risk we're putting people at? They can come back, they recover. We actually have the data that says the optic disc edema goes away. told you the choroidal engorgement goes away, but the choroidal folds will stick around, but they were just a scar of what happened. They're not an ongoing pathology. But if we put someone who had that one time in spaceflight, will they get it again, or will they get it worse, or they become resistant? And does their body know what that is? It now knows how to respond. It's better at responding, better at compensating. We have all these questions about repeated exposures. And also longer-term flight. I mentioned, some of the constraints around extrapolating from 2-week data to 6-month data is a very hazardous way to go about business. But sometimes that's all we have. So you do your best to build the data set that you can extrapolate from. But again, we have limited constraints, our ability to work in flight with imaging, our modalities, the type of data collection you can do, the fact that research and operations compete with each other for time, crew time in particular. So all these different priorities are being managed over time. And so we don't always come out on top in terms of the priorities, but we try to make the case of when we have a real concern or a real risk we need to characterize, we go to bat for the time and the resources to do it. So, and that's pretty much, I think, the state of VIIP and kind of the overall picture. And is there any other questions before we close out for today? Sure.
In general, what's the percentage of crew members that are showing permanent visual changes that I've shown so far?
So what are the permanent?
What's the percentage?
The percentage? I think it's that have permanent change. Well, permanent, so the definition of permanent.
It's like post-life.
We call it persisting. I think we don't. So one other kind of nuance to this of the functional change. What's interesting is that, remember we mentioned the age of the astronauts, now about 46 years old. You are really at the prime age when your vision changes anyway, right? So by itself, functional vision change hasn't been the only thing we've been, that's smart to characterize as a permanent change. And to be honest, we think it was masked for a while, and we didn't look at the back of the eye because the front of the eye was doing what it needed to do to compensate when you're young enough and the muscles on the sides of your eye are strong enough to change the shape of your eye. So I don't think it's a very high percentage. I'm going to look at Melanie again. I don't know off the top of my head. I mean, we'd have to get Sarah. Okay, so we can get that data, but I mean, we talked about it a couple weeks ago, and it's not. To give you a perspective, it's exactly, their eyes are changing exactly like the population of that age who are not astronauts are changing. So nothing is calling out to us and saying 10% of the astronaut population who have flown long duration are having.
And even if they have choroidal folds, which the marks will still be there, most of them aren't having vision changes. So even if there's changes, but it doesn't affect their vision.
Yeah, so this is why the complexity. So again, the biostatistician helping me out, that if you were to pick any one marker to understand what it means in the big picture, it doesn't work. So you would have to pick, and that's where the CPG was meant to try to drive the more together as a group. These symptoms represent something that's unique to astronauts and something we need to pay attention to that's a product of spaceflight. So it would have to be something, because again, we can see choroidal folds and no functional vision change. We see functional vision change and no optic disc edema or choroidal folds, which you would say is probably more about normal aging-induced change and not spaceflight effect.
So it's difficult to distinguish between them.
Very difficult to distinguish right now. So.
Is there any work being done on the, like for example, the eye, the kidney, and some of the tissues have fluid flow in them?
Yeah.
1G. Is there any work being done specifically on looking at, in the swollen scenario where the fluid shift, the traits of the individual epithelia in terms of the response to fluid flow in general? Because the integrity of the epithelium at that point depends on the right fluid flow.
Yeah, like the shear stress. So the question is about looking multi-system and fluid flows and how the body's handling changes in the volume its response, like appropriate or not. I think there are at least 2 studies funded looking at that more comprehensively. I don't have the data, and I can't speak to their findings at this point. I know they have probably not insignificant N. We're talking like they have an N of 10, they probably got an N of 5 right now. So we could get, I mean, I think that's good for the follow-up presentation to start pulling all of the research data that's come out and kind of give you the overall perspective. So we haven't met as a large group to put all that back together because they're still in the gathering phase. We stop every.
There's electrophysiology that you could do in vitro and in animals.
Yeah.
To sort of delineate a little bit and then put it together.
Yeah, I agree. And I think that is the plan, but we can get Christian, Yael, Jennifer Villarreal to come in and kind of give you the overview of where that's going on the research portfolio side. I think it's smart.
What about genetic predisposition?
Genetic predisposition. So you might have heard for the 1-year mission, it's called the twin study.
Yeah.
So, and there's also an epigenetics group looking at more expansive testing, not just for the 1-year mission. So genetic testing and understanding the role of genetics has been very controversial, particularly for a government agency to apply. We've worked on a variety of different policy and trying to understand the ramifications of doing such a thing, because and what's interesting about it, not that it's not necessary to do and understand, but the ramifications go well beyond the astronaut themselves, to their family, their children, people you would, and so to understand how to protect and do it appropriately has been very challenging, which is why no study had currently been funded to this point. So I think this is the twin study and the epigenetics work that NSBRI is kind of spearheading is our first attempt at that. So I think we all acknowledge it's incredibly important, but how we get there is still in work.
Yeah, because the future medical world is
yes.
going towards that.
Yeah, I think personalized medicine and the whole world of epigenetics is appropriate, but we have some additional work to do before we can fund that type of work, to be honest. Good question.
Well, thank you.
Thank you.
I appreciate you. And thank you all for all of the questions that you've asked. I ask that you please, if my secretary will stand up, Ruby Guerrera has the surveys that we're asking you all to please make sure you fill those out before you leave. And as of today, this is the 9th of September? What is
Yes,
it? 9th of September. Our next series is what, Ruby?
The next one would be on the 16th of September.
And what is that one?
That one is Reducing Risks of Exploration Missions, the VIIP Elements Research Strategy.
Okay, so that one is in Saturn now.
Yes.
People can sign up. And so we have that for the 16th. And then the end of the month is we don't have anything on in the rest of September, October.
That'll be it for September. In October, we do have
John Clark is coming on the 2nd of October to do the risk of human spaceflight.
So who's speaking on the 16th of September?
the 16th would be
Whitmire.
Sandra?
Sandra Whitmire.
All right, so please sign up, continue to support us, and earn those certificates, and get an overview of what's going on. And we appreciate Jennifer doing it, but one of the things that we are looking to do is to give some exposure to others in the field who are, as she said, Christian and different other people, so it won't always be the same person. We're gonna have different folks speaking and allow you all to ask questions and expand your knowledge. So thank you for coming, and please sign up, and we look forward to seeing you again.